And I was like, Michael was sitting there just staring at me on stage. In like the end where everybody was happy, I was like, I'm like, okay, this is how I want my face. You can do it before I like process. I like yawning. You already had it. And I could not stop thinking yeah, that was watch him. It was stuck in my head because I seen that one. I started well, you know, I'm sure it was great. I'm so. What did you say? It was so crazy. I'm not Erica. Only thing getting me through this class. Don't worry about it. It was so funny. She was just like, way I don't know why it was like, it's interesting.
All right, folks, sorry for the late start. It's been one of those evenings, so. Now we're getting started. We've got some folks who are not their best selves, shall we say. So they're on Zoom and hopefully they can hear me. If they can't, hopefully, can you guys all hear me? Can you guys?
Yes, I can.
Okay, thank you, Hannah. Okay. All right, so Parkinson's and then anti-seizure meds. And then if we have time, we'll do benzos. Very good. All right, just very quick review. So the midbrain contains a structure called the substantia nigra. The substantia nigra, if you take a transverse section through the midbrain, you see towards the back these black lines. Those black lines are the substantia nigra. They contain dopaminergic neurons. There are two pathways from the substantia nigra to the basal ganglia and then to the motor cortex. There's a direct and the indirect pathway. The direct pathway promotes movement. The indirect pathway inhibits movement. So very quickly, the substantia nigra has dopaminergic connections to the striatum. There's two receptors on those neurons. There's a dopamine D1 receptor and the dopamine D2 receptor. The dopamine D1 receptor causes a excitatory postsynaptic potential, an EPSP. The D2 receptor, when it's bound by dopamine, promotes an inhibitory postsynaptic potential, IPSP. So here's yet another example of the same neurotransmitter producing two different effects depending on the receptor. You guys hopefully have by now have seen that over and over and over again. So when you say, yes, glutamate, yeah, glutamate is an excitatory neurotransmitter. Yeah, that's true. Serotonin is predominantly an excitatory neurotransmitter. Yes, sort of, but it depends on the 12 different serotonin receptors that serotonin binds. Because some of the serotonin receptors, in particular, the HT1A receptor, actually, when it binds serotonin, inhibits serotonin release. So not all receptors are created equally. If you learned nothing else from your physiology class, but I sure hope you learned a lot more than that from your physiology class, you learned that. So for example, norepinephrine, if it binds the alpha-1 receptor, what does it do to blood vessels? Constricts them. If it binds a beta-2 receptor, what does it do to blood vessels? Dilates them. So beta-2 receptors are on the blood vessels in muscles. Alpha-1 receptors are on the peripheral blood vessels. So you constrict, you send the blood to the core, you send the blood to muscles and things like that. Same neurotransmitter, two completely different responses on virtually the same cell type, smooth muscle. Same thing with dopamine here. You get two different responses based on the receptor. D1, EPSP. D2, IPSP. All right, so the direct and indirect pathways are going to modulate movement. In Parkinson's, you get programmed cell death of those dopaminergic neurons. That will tend to diminish the direct pathway and increase the indirect pathway. So movement now becomes lethargic, difficult, and these patients get so-called hypokinetic. Their posture goes south, they get the stooped posture, and they get the shuffling walk. The other thing you'll see in Parkinson's patients, and if you've ever cared for one, you've probably seen this rigidity, tremendous rigidity. The hands, if they walk, they'll tend to put the hands like this. They will not usually swing the arms. Also, if you try to bend the arms, they're very rigid. You try to move the head, you'll encounter a lot of resistance, a lot of rigidity. So you also will get resting tremors typically. So these are the sorts of things you'll see with Parkinson's patients. The other thing you'll see is do you guys know what a Romberg test is? So the Romberg test, you have the patient put the feet together and see if they can do that without falling. And if you have a patient do that, what do? Because they're supposed to close their eyes. Supposed to do this, close your eyes, and then you get those hands out there. Because if they fall on your watch, that's bad. So you're going to steady them. And some practitioners will have you put your feet together, cross your arms and close your eyes like that. That's actually harder than if you keep your arms down like this. That's the tad harder. So you do this, and usually the Romberg sign will be such that they will usually will have trouble. There's another test, it's called the pull test. Need a volunteer. I don't want you. Not gonna hurt you. You need to get up. So stand right here and face that wall. All right. Now I'm going to pull on your shoulders. You're going to resist me. Okay. You ready? All right. Now notice she took once, maybe a small step back. That was it. A Parkinson's patient would do that. Okay. Now the front test. Okay. I'm just going to push you. You're going to resist me. Okay. Ready? Okay. See, she's got it on her tippy toes. Parkinson's patients will be negative pull test in the back, positive pull test in the front. They'll be able to get on their tippy toes and resist that. You pull them back, that's a negative pull test. Okay, thank you, Jenna. So those are quick tests you can do for Parkinson's patients, and then you can just take the arms and you'll feel the stiffness. It'll be apparent. And then you hold the hand and then watch and see if the hand. It's usually one, sometimes it starts in one hand and then usually spread to the, although one hand might be worse than the other, typically. And usually you just hold the hand and you'll just see it. You'll see the tremor, usually. Some patients don't get a lot of tremors. It's pretty common though. It's pretty common. So with Parkinson's, because you don't have that dopaminergic input from the substantia nigra, your balance between the direct, indirect pathway is not balanced. And you get the movement disorders that are associated with Parkinson's. So your job, your mission, should you choose to accept it, is to increase dopamine levels in the brain. So you're going to use levodopa. Can't use dopamine. Doesn't cross the blood-brain barrier. So use a precursor to dopamine, levodopa. That gets converted by DDC, dopamine decarboxylase, into dopamine in the brain that increases the brain levels of dopamine and can do a pretty good job of fixing the movement issues, at least for a time. They're also going to give levodopa with a second drug called carbidopa, because levodopa can be converted to dopamine peripherally. That leaves less levodopa to enter the brain. By giving levodopa in combination with carbidopa, you're able to spare the dopa for admission into the brain that increases levodopa and therefore dopamine levels in the brain. And that helps increase dopamine signaling in the brain and helps with the tremors and the movement issues and things like that. This drug for years, the combination carbidopa, levodopa, was called Cinemet for years. It's available now in a generic. It's relatively inexpensive in the generic. It's for a month's supply, about 25 bucks. So not going to break the bank, relatively cheap. And then some pharmacies will even have programs where you can get it for even cheaper than that. And it is paid for by Medicare, Medicaid, that sort of thing. What have you. All right. Questions about this part before we canter on? Any questions? Have you cared for a Parkinson's patient? Anyone? If the stiffness? Yeah. And the stiffness, it's great. It kind of starts here and goes this way. The head, the neck in particular, very stiff. And the walk, yeah. All right. Now, ATI said, the narration said that levodopa is not sold by itself. That's not true. I will give you some examples of formulations that are sold by themselves. Now, I doubt you guys will administer it because these things are usually prescribed and administered by neurologists who usually, in many cases, specialize in Parkinson's or something like that. So what you will usually end up administering will probably be the combo. But there are formulations of levodopa by itself and carbidopa by itself. So anyway, so for the first 2 to 5 years of treatment, it varies from person to person, but the mean is 2 to 5 years. You get a good, consistent response that lasts half the waking time usually. As the dopaminergic neurons in the substantia nigra start to die, your benefit from the dose now starts to get shorter and shorter and shorter. So that 5 to 6 hours now becomes more like 4.5 to 5.5 hours, 4 to 5 hours, 3.5 to 4 hours, so on and so forth. And so you fluctuate between mobility and immobility. And when the medicine wears off, it's like somebody flipped a switch. It's just remarkable how quickly someone's symptoms can really come back very quickly after the medicine wears off. So this is called the on-off effect. And then after 5 to 8 years, most patients will experience fluctuations between reasonable movement and the hypokinesia associated with Parkinson's. They'll also start to get some dyskinesia, that is tics and things like that. The tics can be things like this or things like that or things like that. They could be really minor. You might miss them unless you have worked a lot with these patients, you know what to look for. Caitlin, did your patient have any tics that you were aware of? How long had they had Parkinson's? Okay. These, oh, okay. Those usually develop when someone's had Parkinson's for a bit. So you also start to get the things that become levodopa resistant. So difficulties with balance, you get the negative Romberg sign, the gait issues, shuffling gait, dysarthria, speech problems, dysphagia, swallowing issues, and then other types of non-motor symptoms and sleep disturbance, cognitive disturbance, so on and so forth, and what have you. You can up the carbidopa, levodopa. You can only up it so much or else you're going to really start to have some side effects. Or you can start to add on drugs that will now lengthen the period of time that dopamine is active in the brain. And that's usually the strategy, is to start to grow on top of the carbidopa, levodopa, other drugs that increase the effectiveness of the levodopa carbidopa combination. So formulations that you get as people have trouble swallowing, you can start to use orally disintegrating tablets. There are extended release tablets, and there's also an enteral suspension. The immediate release tablets can be crushed and mixed in a soda. That's actually used off-label for the hypomotility episodes. If patients have GI issues, because Parkinson's will cause the GI tract to slow down, there is a version of levodopa, carbidopa, that is given through a jejunal administrative device, through a so-called PEG-J2. Because with the problems with gastric entry, the absorption can be erratic. So the jejunal administration, this product is called Duopa. Duopa is expensive because when you buy the material, the suspension, you also have to get the pump. And it's only administered through specific pumps that were designed to be administered with this particular product. So the Duopa is, so this is with the PEG-J, and with the pump is $6,000. So that's not cheap, but that's for everything. Yeah, I've got that right, $6,000. And that there's a specific pump. It's a so-called CAD legacy pump that you administer it with, and you would hook that essentially up to the pump with the Duopa, and you would administer it that way. So this is a 16-hour continuous infusion using that type of percutaneous pump, essentially, that dumps it right into the jejunum. This is an inhaled version of just levodopa. You don't need the carbidopa because when you use it intranasally, it's now right at the cribriform plate. So it goes straight up essentially into the brain. That's why you don't need to use it with the carbidopa. So this comes as a dry powder formulation. You inhale it, and it's especially useful in those with the delayed gastric emptying. Yeah, the people with advanced Parkinson's may find it difficult to use. So that would be your job, would be to help them use it. That's called Inbrija. Inbrija. That's levodopa only in an inhaled form. Let's take a look at some of the side effects, because levodopa is not without side effects, of course. So there are peripheral side effects of levodopa. They can upset the stomachs. They can cause nausea and vomiting. The upset stomach can cause people to not want to eat. Weight loss can be a big problem in Parkinson's patients. Making sure that they can get enough nutrition is sometimes a challenge because they just don't want to eat. And if you give them great food, they will just leave it sometimes just because they're just not up to it. It can also cause orthostatic hypotension. That's usually the case when they first go on it. That tends to wear off usually. If you treat them with it routinely, you can start to get some tics, particularly as dosages start to go up. It can start to cause people to fall asleep. Kind of sleep attacks, narcoleptic type sleep attacks can be an issue. So with narcoleptic sleep attacks, that means there's a falling risk. So you need to be very careful with these patients if they're walking about. They can have hallucinations and vivid dreams, hallucinations during their dreams or waking dreams that consist of hallucinations. Delusions, sometimes these are benign. I have a former patient, she's the first year we had the nursing program. She's working Jerry Psych in Kalamazoo. And she has a patient with pretty advanced Parkinson. And this dear lady is convinced that Mary is her daughter. So she keeps asking about the kids and stuff like that. And Mary just makes stuff up because she doesn't remember it next time she asks her. So Mary's got this whole storyline she tells her. And she asked her about her childhood injuries that she had and the ribs that she broke when she fell out of the tree. Does that still hurt when you breathe? It's just so. Mary got into that line of work because she's very good with elderly people. And she says, oh yeah, no, I'm breathing fine. See, no, I breathe great. So They can get confused and they can get really frustrated when they get confused. And I don't have any formula as how to deal with that because it's frustrating as much for you as it is for them. So if anyone has a nice suggestion, let me know, because there's really, I don't think there's any, you just have to be patient. Agitation can occur. Agitation is more common in male patients than it is in female patients, but it can occur, particularly in older patients, particularly with older males. Impulse control disorders, they can occur, but not as frequently as with the dopamine agonists. So the hypersexuality, the gambling, that sort of thing, impulse buying, stuff like that. These people should not have control over their money. Someone else should have power of attorney and have control over their money. The inhaled levodopa can cause some irritation in the airways, so coughing, that sort of thing, and what have you. High protein foods can either delay or diminish levodopa absorption. Levodopa competes for the same aromatic amino acid transporters that are used by phenylalanine and tryptophan and tyrosine. So if you, this is particularly a problem if you have them over, say, for Christmas dinner, and you have turkey or something like that. Oh, great, I get to eat turkey instead of that awful other stuff that I get at the retirement home or something like that. So they really bone up on their turkey, then they have to take the medicine. It's going to inhibit the absorption of the medicine. If you're going to use it, you don't use it within 14 days of other things that will increase serotonin levels. You can get a spike in blood pressure. You can get pharmacodynamic interactions with Parkinson's drugs and antipsychotics. There are special antipsychotics for Parkinson's patients that are serotonergic that don't bind the dopamine receptors. So if you give the dopaminergic antipsychotics, they're going to compromise the effectiveness of your levodopa. Those two drugs you just shouldn't give together. And if you co-administer it with an antihypertensive drug, the orthostatic hypotension will be worse. They're really going to be at risk for falls then. So put the belt on them and follow them around. It's for their own good. Any questions about levodopa, carbidopa combos, anything like that? This is pretty much first line. Some neurologists will not go to it first because some people will present with very mild symptoms and their Parkinson's will progress very slowly. And they're afraid if they get them on levodopa, their Parkinson's might progress more quickly. So, but for most people, it's first line. Dopamine agonists bind to dopaminergic receptors and activate dopamine neurotransmission. So they do what levodopa does, they just do it in a different way. Instead of increasing the ligand for these receptors, these things are agonists for those receptors, those dopamine receptors. They're typically less effective than levodopa carbidopa. They're less likely to cause fluctuations. You're less likely to get on-off effects. You also are less likely to get tics, movement tics with the dopamine agonist. So they can be used in a monotherapy, particularly in early mild disease. Within a few years, usually, you'll need to start layering on the levodopa carbidopa. In advanced disease, if you use these drugs, you can lower the dose of levodopa, which will decrease some of the side effects of levodopa. So the two biggies that have been used quite a bit are pramipexole. The trade name is Mirapex, but it's used now in generic, and the generic drug's not very expensive. And then ropinirole. Ropinirole is used a lot for restless leg syndrome. If someone has restless leg syndrome, that's one of the medications they'll get. But it's also used for Parkinson's. Those are oral. Those drugs are relatively cheap. They're used both in early and advanced disease. And another drug is a newer drug, retigotine. Retigotine is available as a patch. Patches can be really convenient because you just put them on and forget about it, essentially. So some people really prefer patches. Now, remember the do's and don'ts of patches we talked about with fentanyl? Flush them. Okay, what else? Rotate spots. That's two. Good. Sorry? Never put them in the trash. Yeah, flush them. They keep them away from children. Yeah. Heating pads. No heating pads. Heat. The drug now will get released a lot faster. Don't put it next to a heater. If you like to sit on the heat register to warm up, like my cat does, if you do that with a patch on, it'll release the medicine really quickly. You'll get drug toxicity. So that's another one. So you guys are 4 out of 5. That's pretty good. So pat yourselves on the back. And here are the patches. You can see they come in different dosages, different size patches, and different surface areas that they cover.
So say you like work out, patch on, is it gonna release faster?
If you have a lot of clothing over it, yeah. If you're trying to sweat and you've got clothing over and you're getting really hot, yeah, it will. So apomorphine is another dopamine agonist. This particular drug comes, as you can see, in an oral form, also comes in a sublingual form. The FDA approved it, but in clinical trials, it tended to irritate the oral pharyngeal cavity. So the recommendation with this drug is use the tablet with the sub-Q form together. Go kind of on off with it if you use this particular drug. That way they can give their oral cavity a rest. So you might get some lower extremity edema with these. It may take a while for that to happen. It's usually not severe. The other issue is that the patient may not be moving very much, so they're not pumping the lymphatics in the lower parts of their body. Sometimes just by getting people to walk a bit, that may actually help a lot with lower extremity edema. Again, if they walk, they should make sure to use a cane, a walker, and if they want to go for a walk, you should go with them. And you should probably have your arm around them or something like that, or have the belt on them or something like that. Sinas, correct me if I'm wrong. Someone's a falling risk, you have to have the belt on. That's regulations, right? Yeah, because I know some patients don't like the belt, but it's kind of tough. You're a falling risk, you have to have the belt. The nausea can be an issue too. There are drugs you can give to reduce the nausea. This particular one, Tigan, is a trade name. Trimethylbenzamide. That one is not a dopaminergic drug. The other antiemetics, metoclopramide and prochlorperazine, those two block dopamine receptors. They'll make the Parkinson's worse, so don't use those if you use them, if you're going to use them for Parkinson's patients. But this one, Tigan, is definitely a drug you can use to mitigate the nausea caused by the dopamine agonists. Of course, sleepiness, hallucinations, also sudden sleep attacks, again, fall risk, potential fall risk. They can also cause confusion and psychosis, particularly in elderly patients. These drugs should not be used in patients with dementia. Patients with dementia are contraindicated. You make their dementia a lot worse. You can also get impulse control disorders, and that's one of the biggest caveats of these drugs. So pathologic gambling, hypersexuality and obsessive viewing of pornography, pretty common actually. Uncontrollable spending, which again, I have to emphasize, these patients should not be in control of their own money. They're not going to like it, but that's the case. Excessive computer use, pretty common with these drugs, unfortunately. If you get impulse control disorders that are recognized, you should taper the drugs and stop them. When you withdraw dopamine agonists, you always taper them. You don't stop them cold turkey because they can lead to physical, psychological symptoms that include anxiety, dysphoria, irritability, fatigue, suicidal ideation, generalized pain, drug cravings. Those are all withdrawal symptoms. So taper the medication. And the provider, the physician, will taper it. We'll write down the tapering schedule. And if you become a nurse practitioner and you're handling the drug is usually published with a tapering schedule that comes in the drug insert. Reticotine patch can cause some rashes and things like that. Some people have gotten discoloration of the fingernails with the reticotine patch, which can really freak people out when your nails turn green or something like that. The apomorphine injection, you can get injection site reactions. And then the sublingual apomorphine can cause oropharyngeal adverse effects. They can cause discoloration. They can cause spasm of the oropharynx and what have you. Yeah. Again, don't use these with antipsychotics that bind the D2 receptor. Don't use them with other CNS depressant drugs. Apomorphine, don't use it with ondansetron, Zofran, which is used for nausea and vomiting. You can get severe hypotension, even loss of consciousness, and even death has been reported after using those two together. Ondansetron is used a lot in hospitals for nausea. So someone's a Parkinson's patient and they're on a drug like apomorphine, you just have to, I think, just write a big note, no Zofran. Questions about the dopamine agonists? All good? Another enzyme that degrades dopamine is this catechol O methyltransferase enzyme. The catechol O methyltransferase enzyme can be inhibited using drugs, and all these drugs end in capone. Al Capone. So just, think of these drugs, get your machine gun out, and remember, they end with capone. So there's entacapone. This is in generic, but the trade name is still available. It's called Comtan. This again is used with levodopa. So the dopamine that is made from the levodopa, its half-life now is a lot longer if you pile these drugs with the levodopa. So it reduces the amount of levodopa the patient needs to take, and it reduces the motor fluctuations. There's also a version of entacapone that comes with fixed dose carbidopa, levodopa, all in one pill, which is pretty convenient. So that's in generic now. The trade name is Stalevo, but it's also available in a generic. And how expensive is that drug? It's not cheap. It's about $300 for a month's supply. So. Opicapone is a newer drug. This drug is similar in efficacy to entacapone, but it's a once-a-day administration and it has fewer side effects than entacapone. So this drug is starting to be used more and more, even though it's newer. Tolcapone is more effective than entacapone. It got pulled from the market in Canada and elsewhere because it's been associated with fatal hepatotoxicity. The FDA was not convinced that the low number of cases could be definitively linked to the drug, so the FDA did not recommend the drug be pulled. It's available in the US, but you have to have normal liver function before you can go on it. The patient also has to give written consent in order to go on tolcapone. So movement tics and nausea and diarrhea. The nausea, diarrhea are worse with tolcapone. You can get urine discoloration with entacapone and tolcapone. With opicapone, you get less diarrhea and you don't get the funny color in your urine. Again, tolcapone, you have to have written consent and you have to have your liver function monitored every 2 to 4 weeks for the first 6 months you're on it, and then periodically thereafter. The other two drugs, there's no liver toxicity that's been reported for them. You can reduce your levodopa dosage on these drugs, which is nice, but sleepiness, once again, and sleep attacks have been reported. If you're taking other drugs that are metabolized by this enzyme, catechol O methyltransferase, then these drugs will have longer half-lives. Also, if you use this with a non-selective monoamine oxidase inhibitor, you will decrease the metabolism of catecholamines and get catecholamine toxicity, increased heart rate, that sort of thing. And yeah, not good. If you use the CNS depressant with the COMT inhibitors, you'll suppress the CNS even more. Not good. Any questions about the COMT inhibitors? Now, monoamine oxidase inhibitors the ones that are used as antidepressants are non-selective. The monoamine oxidase inhibitors that inhibit the B isozyme of monoamine oxidase are the ones that are used for Parkinson's because monoamine oxidase B is more specific for dopamine. That's why these drugs inhibit monoamine oxidase B, and they're used with levodopa. So again, you're extending the half-life of levodopa. So these drugs tend to end in gelyne. So the oldest drug out of this group is salicyline, almost certainly. It gets used as a monotherapy for early Parkinson's. Not the majority treatment, but some people, really some neurologists like it because early patients with pretty non-severe symptoms seems to help. So it can delay the initiation of using Sinemet. And in advanced disease, you can use it with Sinemet and decrease the dosage of Sinemet that the patient has to be on, which is a plus. Rasagiline is another of these drugs. This one's an irreversible monoamine oxidase B inhibitor. And again, also used as a monotherapy, used early and also late disease and so on and so forth. This one seems to be about as effective as entacapone. And then a newer drug, sulfonamide, it breaks the ending, the gelyne part. This is a reversible monoamine oxidase inhibitor. And so it's used as an adjunct treatment to carbidopa levodopa. And it doesn't seem to cause dyskinesia as much. Is it more effective than the others? There's really haven't been any head-to-head comparisons yet. So that remains to be seen. Orthostatic hypotension is probably one of the big side effects of MAOIB inhibitors. Again, because of that, getting up, especially from lying down and having a case of syncope is a genuine problem. So what instructions you're going to give the patient? Get up slowly. When you're getting up from bed, dangle the feet. Grab onto something. Get up, tilt the head. Then very slowly raise the head. If you start to get dizzy, sit back down and then try it again. Just go slowly. And if you need someone to help you, ask for help. Don't try to be, a superhero. Yeah, sulfonamide you don't want to use at higher than recommended doses because the cell activity starts to break down from AOB, and that can cause severe hypertension. If you use them with levodopa, you can get increased dyskinesia and psychosis, particularly in elderly patients. And if you use them with stimulants like Adderall or Ritalin or something like that, or even something like pseudoephedrine that's in cough syrups, you can get a severe hypertension attack. Now, the monoamine oxidase inhibitors, you had to really watch your diet if you're using them for depression, because you need to stay away from foods with tyramine, because tyramine is degraded by monoamine oxidase. At tyramine levels, if they get too high, they can spike your blood pressure. That's not the case with these particular drugs. So you don't need to observe a particular diet when you're on these particular drugs. Serotonin syndrome, if you use them with other serotonergic drugs, is a potential issue, except that the selective monoamine oxidase B inhibitors are used all the time with these two serotonergic drugs, and the risk appears to be quite low. So I'd almost say serotonin syndrome, question mark? It's just not as big a deal. Does that mean you shouldn't worry about it at all? No, you should probably think about it, but definitely not as big an issue. Istradefylline is a bit of a mystery. Istradefylline is a adenosine 2A receptor antagonist. What on earth does that have to do with Parkinson's syndrome? It's used as an adjunct with levodopa when they experience off episodes. How the drug works is not at all clear. It's known that the neurons in the striatum that form part of the indirect pathway have these adenosine receptors, but it definitely diminishes the amount of off episodes. So it's used as an adjunctive treatment to levodopa carbidopa. On the average, the drug is relatively well tolerated. It can increase the risk of impulse control if it's used with other Parkinson's disease drugs. These are kind of the standard side effects you've already seen. Are those more the result of drugs the patient's already on? Maybe it's making them worse, hard to say, but it's an adjunct treatment that is used. This drug is metabolized by cytochrome P450, 1A1, and 3A4. And if you use enzymes that interact, drugs that interact with those enzymes, you can increase the concentration of istradefylline. 1A1, one of the antidepressants that's an inhibitor of 1A1 is fluvoxamine. So that's one to keep in mind. So amantadine was used as an antiviral, but it turns out to be a good drug for tremors that are caused by certain Parkinson's medicines. So it's used early as a monotherapy. It is an antagonist of the NMDA receptors. Glutamate is thought to play a role in the tremors and the dyskinesias. This is an old drug. It's a very cheap drug. It's a pretty well-tolerated drug too. So it's used for tremors that are resistant to levodopa treatment and what have you. In some patients, the benefit is short-lived. In others, it's longer-lived. There's an extended release formula and other formulations that you can use that cost less, and they decrease the off episodes with patients. This drug has anticholinergic effects. Anticholinergics, when you give them to elderly patients, can really increase dementia. They can increase hallucinations and things like that. The other things, dry mouth, constipation, urinary retention, are all possibilities. Other things that you see, dizziness, myoclonus, insomnia, so on and so forth. The other thing in overdose are the arrhythmias. That's a big thing to worry about with the arrhythmias. Don't withdraw this drug suddenly, taper it. And if you give it with other anticholinergics, it'll make those anticholinergics worse. Don't take it with alcohol. And if you give amantadine with other drugs that prolong the QT interval, you can get the torsade des points, the twisting of the points, that arrhythmia, which is very severe. We'll talk more about that when we get to antiarrhythmics. Okay, very quickly before we take our break. Anticholinergics are used for drooling. Used for drooling, and they're used for treatment of tremor as well. There's two that are used. Benztropine is probably the one used more commonly. That's cogentin. And then there's trihexyphenidyl. And the side effects of anticholinergics, dry mouth, they can make your glaucoma worse, urinary retention, they can increase cognitive decline, blah, 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 so on and so forth. Don't discontinue them abruptly and what have you. These drugs in elderly patients use with caution. If you're going to use these drugs in patients who are elderly, talk to the family, tell them what to expect. Make sure you bring the family in on the use of these drugs. All right, anything about any of those drugs we've talked about? Yeah.
It was one of the drugs that you're talking about, and you said that you wouldn't use it with levodopa carbidopa, but I was reading the ATI and it said that it was used. So the monoamine oxidase type B, it said giving with levodopa carbidopa prolongs the effects and enhances the effectiveness of both.
Yeah.
Okay.
Yeah.
Okay. I just wanted to make sure.
Oh, yeah, that's used as an adjunct with levodopa often.
Okay.
Very often. It will enhance some of the side effects of levodopa. That's the case really with all these adjunct medicines. So that's something to just keep in mind. But no, it's used a lot with. Did I say you're not to use that?
I think you said not to use it together with it.
No, you can use it. It's used as an adjunct with. It's also used as a monotherapy early on. But it's used also later for later Parkinson's disease as an adjunct treatment. All right. A lot of drugs, huh? A lot of drugs, yeah, too many. Okay, let's take our break, come back and look at drugs for seizures.
No, but it just wasn't enough.
Did you?
We had our conference week this weekend, so like they're all not well. Not as well as kind of a bummer, but okay. So
Just time.
I know, seriously. It's okay.
You ready for outdoor?
Yes, I am. I'm on it right now. Don't do it, Nikki. Do you have a library card?
I have too much to do. I didn't know swimming, so that was so.
Me too, girl.
And I just remember certain stuff like that. This is a week before mine, and my family. So anyway, I was after mine. That's it. Yeah. You're like, wow. That's great. Yeah, I don't know, like, I'm not, I don't know, but like, I've just. We're at the fast track. I'm more.
Okay, time to get back in the saddle. Yes, Miss Caitlin. I thought it was. Is it not?
Is that what it's like listed as?
Yeah. Did not that? Do you not see it? Now look. That better? Okay. All right. This particular link here is to a YouTube video that's put out by the National Health Services of Great Britain. It is by far, from what I've seen, one of the best explanations of seizures, the different types of seizures, and really, really strongly recommend you watch it. There is a neurologist who talks about it. He, of course, has a wonderful high-class London accent. And the people who enact it are all actors, and they enact essentially having the different types of seizures. So the terminology of seizures has changed a bit. So I'm going to trust you're going to watch this, okay? Right? All right, good. Sorry? I'm sure it does, yes. Okay, so the generalized onset seizures refer to seizures that involve both sides of the brain. So with a seizure, you have brain activity that is unregulated and it spreads to other neurons in the brain. And pretty soon you get this activity in the brain that will cause someone to either zone out, to have some sort of jerk of their muscles or something like that, to fall down and then start to tense up and do the tonic-clonic thing, what have you. Generalized onset seizures were formerly called things like tonic-clonic seizures, where you fall down and you start to seize and then relax and so on and so forth. There's also so-called atonic seizures, where someone essentially just goes limp and goes, or like that. And you'll see that in the video as well. Now, what used to be called partial seizures are now called focal onset seizures. Focal onset seizures. They start in one area or group of cells in one side of the brain, and they tend to stay to that one side of the brain. Sometimes people are aware of their seizures. Sometimes people are not with focal onset seizures. Then there are this kind of ill-defined group of seizures. They're just kind of unknown. You get seizures where people will all of a sudden, they'll be holding something and all of a sudden their hand will throw off. That is just called a tonic seizure. My niece, my wife's brother's daughter, Erica, she'll graduate from high school this year. She gets absence seizures. And before Erica got on medication, Erica would look at you, be talking, all of a sudden she just, Erica, and she had absence seizures, and now her absence seizures are very well controlled with topiramate. So your generalized onset seizures typically will have motor symptoms. These include usually jerking movements. That's the clonic part. Then you get, after the clonic part, you get weak part, the atonic part. The brief muscle twitching, that's called myoclonus. And then the epileptic spasms where the body flexes and extends repeatedly. So absent seizures can involve just a staring. And then absent seizures can also have brief twitches, myoclonic twitches, that sort of thing. Now, with the absent seizures, usually the patient is completely unaware of the time that's been lost. They will just all of a sudden think that the time essentially didn't pass. They begin, they end abruptly. They usually only last a few seconds. They can be mistaken for daydreaming. They're more common in children. They're easy to miss, consequently. The tonic-clonic seizures, this is kind of what you are more familiar with, formerly known as grand mal seizures. The term grand mal is no longer used, so tonic-clonic seizure. Begins on both sides of the brain. The patient will lose consciousness. The muscle will stiffen. Jerking motions will occur, and they will last 1 to 3 minutes. Atonic seizures are also known as drop attacks. The patient will fall, very short lasting. Atonic simply means that the patient has lost the tone of their muscles. So clonic seizures involve jerking of a part of the body. They can begin in one area of the brain or on both sides of the brain. You can't stop them by restraining the patient. And with tonic seizures, the body, arms, or legs will suddenly stiffen up and tense. They usually begin on both sides of the brain, but they can also begin in just one area. Excuse me. With a myoclonic seizure, you get a brief jerk of the muscles. These are very short, and the patient's usually completely aware of what's going on. Focal onset seizures, there's a really nice vignette in that YouTube video where a guy has a focal onset seizure where he all of a sudden stops, he's playing soccer with some guys, the British call it football. He's playing soccer, and then all of a sudden he just goes off and he starts doing this to a sweater, and he does that, and he all of a sudden just starts walking off, and it's just a seizure, and then he'll usually come to, and then it's usually not an issue. They can also be non-motor in nature as well. So focal seizures begin on one side of the brain. There's no loss of awareness. They seem to be the most common in epileptics. Focal onset with impaired awareness. In this case, the seizure can last 1 to 2 minutes. The patient's not aware of their surroundings. And they may include the so-called automatisms, where they do this to their clothing and they do chewing, lip smacking, and what have you. So depending upon where the seizure originates in the brain, you can get sometimes auditory hallucinations during them. You can all of a sudden get changes in sight. They can cause disruptions in behavior. It depends essentially where they originate in the brain. These seizures are very rare. Gelastic and dicrastic seizures. The gelastic seizures are laughing seizures. Patient just bursts out laughing and will just have a good laugh and have no idea why they're laughing, and then they come out of it. Dicrastic seizures, you have uncontrolled crying, where the patient will just break down and have a nice, good cry and then come out of it. Yes, I know, it sounds like puberty, huh? That's what my girls would say. These sorts of seizures are usually not controlled by traditional seizure medications. So your motor seizures are described as either tonic-clonic or epileptic spasms. Non-motor seizures usually include some sort of behavioral arrest. Febrile seizures are associated with a high fever. They usually occur in children. And it's usually kids aged 3 months to 5 or 6 years. Tend to run in families. People who get febrile seizures are not at higher risk for epilepsy. So that's not the same as a typical epileptic seizure. People also, when they are undergoing really high stress, can have a seizure all of a sudden, and then they never have any more seizures the rest of their life. These are non-epileptic seizures. This happened to my sister-in-law after my brother lost his job in Whittier, California, before they moved to Florida. She all of a sudden had a seizure and couldn't drive for 6 months, which was a drag. But that was an example of a non-epileptic seizure. Seizures that fail to respond to traditional treatments. These can result in a condition called status epilepticus. The video in ATI talks about status epilepticus, and that's a medical emergency. All right, let's talk about the medicines. So to treat the seizure, you turn down the activity in the brain. So virtually all the drugs that are used to treat seizures are drugs that will either do things like inhibit voltage-gated sodium channels, inhibit voltage-gated calcium channels, increase the activity of GABA. All of them have to do with turning down neural activity. So all the things you can think of that are responsible for neural activity, and then all the things that you can think of that inhibit neural activity, anti-seizure meds will either potentiate the things that turn down neural activity or inhibit the things that elicit or cause or facilitate neural activity. And many of these drugs have more than one mode of action. So it's very hard to kind of put them in particular categories in some cases because they overlap a lot. So your voltage-gated sodium channel blockers, they include carbamazepine and its derivative, oxcarbamazepine. It's not on there, but valproic acid will also inhibit calcium channel blockers, as will phenytoin and lamotrigine. And many of these medications have other mechanisms as well. But by blocking voltage-gated sodium channels, where voltage-gated sodium channels found in the neuron? Yeah. Where else? The axon, gang. The axon. Remember, for the axon, it's an all or nothing potential. If you block the voltage-gated sodium channels, the axon's not going to fire. So that's a pretty surefire way to put the kibosh on seizures. There are several that are going to potentiate the activity of GABA. And these are your barbiturates and your benzodiazepines. So clobazam is a benzodiazepine. Phenobarbital is a barbiturate. They enhance GABAergic activity in the central nervous system. Phenobarbital is one of the drugs of choice for status epilepticus. Please hear me when I tell you barbiturates are addictive. So they should be used essentially as a last resort, and they should be used short term. There are other drugs that are going to inhibit your calcium channels. So when the action potential gets to the axon terminus, you have voltage-gated calcium channels. They open, calcium comes in, and that will potentiate the fusion of the neurotransmitter-laden vesicles with the synaptic membrane, releasing neurotransmitters into the synaptic cleft. There are two drugs in particular that are good blockers of those calcium channels. So ethosuximide and valproate. Valproate actually does kind of quadruple duty in some ways. Valproate also enhances GABA activity because it inhibits the enzyme that breaks down GABA. So it's GABA transaminase. GABA transaminase degrades GABA, and valproic acid inhibits GABA transaminase. So GABA kind of does lots of different things. Okay, so these drugs here, you have drugs that inhibit the calcium channel blockers and then glutamate inhibitors. Glutamate is a excitatory neurotransmitter. If you block glutamate inhibitors, you'll prevent EPSPs. That'll shut down a seizure. And topiramate is one of them. Topiramate does other things as well. And then you've got other types of channels that are blocks and then other things. This drug here, levetiracetam. Levetiracetam is a pretty widely used anti-seizure drug. People have guesses, but no one's really very sure how it works. But it's a very good anti-seizure drug. And how it works is still a bit of a black box. Gabapentin is also a calcium channel blocker. And various other blockers and things like that and blah, blah, blah. So you have a nice target-rich environment when it comes to neurons and the postsynaptic cell. And so these different types of anti-seizure meds essentially hit lots of different targets. So here's a piece I want you to know. Anti-seizure meds take the knobs of the brain, turn it way down. So activity in the brain goes from this to this. So your chances of having a seizure go down. They can, in some cases, stop a seizure, and they can prevent a seizure from happening. All right, let's talk about using them. So this is a treatment algorithm, essentially, from up to date. And from that, we essentially get this. So for your partial and generalized tonic-clonic seizures, your drugs of choice are carbamazepine, valproate, lamotrigine, phenytoin, which is a pretty powerful anti-seizure drug. Gabapentin is a weak anti-seizure drug. It's used as an adjunct. But topiramate can also be used as well. For generalized tonic-clonic seizures, here's the list pretty much I just gave you. Carbamazepine, valproate, lamotrigine, phenytoin, topiramate, and then gabapentin used as an add-on if needed. For absence seizures, the drug of choice is ethosuximide. It is an absent seizure specialty drug. In children, you can also use topiramate. These other drugs as well have been used. Their efficacy is in a bit of doubt. For status epilepticus, IV Valium, diazepam, phenytoin, or phenobarbital. All right. Side effects. Carbamazepine has a lot of drug-drug interactions. It's a pretty potent inducer of cytochrome P450s. So that's the first caveat with carbamazepine. Carbamazepine can also affect vision. It can cause something called diplopia. Diplopia is double vision. The vision might be stretched, double vision. You can have balance issues, ataxia, where you're not as sure on your feet. It can cause liver toxicity in some people. It can cause increased white blood cell counts, agranulocytosis. And then the other thing about carbamazepine is that it can cause something called syndrome of inappropriate antidiuretic hormone. What does antidiuretic hormone do? It causes you to make a more concentrated urine and preserve water. If you're preserving lots of water, what's that going to do to blood volume? So what's it going to do to blood pressure? So that's an issue with carbamazepine. Carbamazepine is also not safe during pregnancy. It increases the risk of cleft palate, neural tube defects like spina bifida. So don't use it during pregnancy. Carbamazepine. Clobazam is a benzodiazepine, so it basically causes you to be very tired, very sleepy, and drunk. That's kind of thing with benzos. So more or less, all these, it's, you know, you're just kind of drunk. That's the thing about benzos. And this one's a benzo, and that's essentially what it will cause. Let me get to ethosuximide and then we will call it. So ethosuximide is a drug with a pretty long half-life. On the average, it's well tolerated. Nausea and vomiting go away. Those are not long-term side effects. Drowsiness can cause some sleep disturbances in some kids. Hyperactivity in others, but it's usually not much of an issue. Okay, we will pick this up on Wednesday. We'll do the anti-anxiety drugs, the benzos, and then buspirone, and then we'll go on to osteoporosis and rheumatoid arthritis. Okay, crew. Have a good evening. If you guys have any questions, feel free to ask them, please. Claire, I hope you feel better. I know being sick's a drag. Hannah, nurse that knee.
Thank you.
You're very welcome.
Will
Thanks
do.
for coming.
Thank you so much.
Yeah. So are you icing it, Hannah?
Yeah, I am. And then I have my appointment tomorrow at 9 a.m. And then I'm hoping that they can squeeze me in for an MRI tomorrow.
Does it hurt?
Yeah, it's really swollen too.
Oh, crumbs. Okay, well, we'll see what happens then. Fingers crossed.
Yeah, thank you so much.
Yeah. Have a good evening.
Thanks, you too.